I'm going to present some of the science from our project, but I really want to leave a lot of time for discussion, frankly, because this was a project that I was very passionate about, and we just wrapped it up about a month or two ago, and we had a fantastic professional relationship and collaboration between my research team and the India Cultural Center in South Jordan. So the project, we had to come up with an acronym. I'm a cardiologist at the university, and cardiologists like having research studies with acronyms tied to them. And so the acronym we came up with is the Utah South Asian Cardiovascular Health Initiative, or USACHI, which was, our project was to see the feasibility, the impact, and participant feedback of a community-based screening and health intervention program. And as I mentioned, this was a real partnership between a whole team that I worked with and a lot of the ICC community members. Of course, it was funded by this team, the team here, and all of their work. Briefly, I'm going to just touch on a little bit of background, what is known locally. I'm going to touch upon the work we did with the CCET, specifically putting together a community advisory board and receiving feedback on how to make our grant proposal stronger. The partnership plan that we had with the ICC. I'm going to briefly go through some of the results from our actual health screening and participant feedback on what we did over the last year, and then of course leave room for discussion and future directions. So this is an issue, it's near and dear to my heart. I'm South Asian, I'm a cardiologist. South Asians are 4 times more likely to develop cardiovascular disease than the general population. Generally speaking, South Asians can develop coronary disease or blockages in the heart arteries at a more premature and more aggressive rate than most other ethnicities. And this is known by anybody that's really practicing in cardiology or people that spend time in the South Asian community. Everyone has a friend, cousin, uncle who had a heart attack in their 40s, and it's well known within the community. And what we wanted to do was shed some light on, do the same issues occur with South Asians residing in Utah? So South Asians in the United States, high burden of premature heart disease, as I mentioned. Believe it or not, if you're guiding patients on cholesterol management, just knowing that their ancestry is South Asian is considered an independent risk enhancer in the cholesterol guidelines. The reasons for this are pretty complex. Some of it's genetics, some of it's lifestyle, and some of it's certainly a high burden of traditional risk factors, diabetes, obesity, cholesterol, as well. As a result of this, there's a high likelihood of mortality from coronary artery disease among South Asians compared to the rest of the population. So focusing locally, Utah has over 100,000 Asians. This number is growing as the population diversifies. There is a large and growing number of South Asians in the community, particularly with a lot of the tech companies that have found their homes here. A lot of people come here both in that industry, have come here working on visas, have come here like myself to work at the University of Utah. And so the immigrants that are coming that are Asian, immigrants from India represent the second largest population coming to Salt Lake City. And interestingly, Utah, generally speaking, is regarded as one of the healthier states in the country from a heart disease perspective. So of course, as you can imagine, we wrestled with this issue of, well, how much does living in Utah help you from a heart disease perspective, or how much does being South Asian still work against you? And that's why we wanted to do our screening efforts locally. So our aims or the goals of our study were twofold. One was to characterize the risk markers and also from a public health perspective, the barriers to optimal care for South Asians that are living in Utah. And this was done in partnership with the Wellness Bus, which I'm going to talk a little bit about, and as I mentioned, a real partnership with the ICC. We also wanted to evaluate the impact of a program that we developed. It was a lifestyle intervention program with once a month in-person sessions in which we covered a broad range of topics that I'm going to show you some details on. And the goal was for everyone that completed that program, we tested their risk markers. These are things like blood pressure, cholesterol, lipid markers, test them before the intervention and then test them after. As you can imagine, our goal was to show that just through education at the ICC and people spending time going through these topics, that we could actually improve their cardiovascular health. So probably almost 3 years ago, 2 years ago, I want to 2.5 years ago, we worked with the CCET closely, and we developed and we disseminated a community needs assessment. And I'll tell you from my perspective, I had not done this type of research before. I had not done a lot of community engaged research, and so the CCET and frankly Louisa Stark guided me quite a bit early on in the process because this was new to me as well. And Dr. Stark reminded me early on that my objective is not to go into the community, collect a bunch of blood samples, and then run away and never talk to them again, right? The goal was to understand what the community needs, and hopefully it matches what my interests are, which I've kind of already shown them to you. And we started by an actual survey, and so we hosted, you can see a photo on the bottom right, we hosted an event with the CCET support. There was certainly food and beverage as well because people were taking their valuable time on a weekday to spend time with us. And we asked questions about how concerned are you that you will develop heart disease? 59% very concerned, somewhat concerned. Before taking this survey, were you aware of the high rates of heart disease in the South Asian community in the United States? 56% no. Would you be interested in receiving more info on how to prevent or manage heart disease? 77% yes, in person, online written content. And this, when we first met, this was probably not peak COVID, but COVID was slowly coming down. So there were a lot of mixed feelings about in-person sessions, virtual sessions, how are we gonna actually work together? And then importantly, if there was a healthcare clinic focused on preventing and treating heart disease in this community, likelihood that you're gonna use it, highly likely, 75%. So we use the input from the Community Advisory Board when we applied for the CAPP a couple of years ago. We actually applied twice. We applied once, received a lot of helpful feedback, put together this Community Advisory Board, received all of their feedback, reapplied a year later, and that led us to our actual project, which, as you can see from the images here, what our team put together was we worked with the Utah Wellness Bus. Hopefully everyone's maybe heard of this resource. It's a fantastic mobile health clinic that works with the University of Utah, the Diabetes Initiative. During COVID, they were doing a lot of COVID testing, but traditionally they do a lot of health education, health screening, and they're a great resource because we were able to leverage their resources for blood pressure, A1C, and lipid checks all through point of care or finger prick testing. The bottom left is ICC. It's in South Jordan, large community center. It's right next to a large Hindu temple. I myself had gone a little bit when I began, but once I started this project, I should have mentioned earlier, this project, part of the genesis was there's a senior faculty member here on the pulmonary side, Krishna Sundar, who was both a research mentor of mine, and he was also a community mentor because he was able to say, hey, I'm a part of this community, you should be a part of this community, so you need to start coming. So even before the project took off, I found myself there more and more on the weekends getting to know people because it made a lot of sense if I was gonna actually work this closely with this community. On the right, you can see some of our images. So we had a health report card for everybody that came and participated in the screening. It gave them their data to take home with them because a lot of times when you have your blood pressure checked or your cholesterol checked, you don't know exactly what to do with it. And so we provided both a report card so you could take it, bring it to another doctor, work with us, work with myself. A lot of these individuals came and saw me as a patient as well, but it gave them something that was tangible they could hold on to. And on the right was a flyer we developed, and we basically posted this flyer, community centers, and every South Asian restaurant you could find in Utah, and it made a big difference. I say that because our goal was over 2 different sessions was to try to get 100 people total. And over 2 sessions, we actually had 179 people, which was great. Our first time, we actually had to, we almost had to turn some people away because there were so many people coming in. There was a compensation gift card for participating. I want to say it was $25, may have been $50. But there was a compensation component, but moreover, people wanted to know their numbers, right? People wanted to know what is my cholesterol, what is my A1C. And so this is just some of the data that we collected. This is all being worked on in a manuscript now to be published, but mostly the people that came were around, you can see their age was in their 40s on average, a little bit more men, primarily Indian descent, even though, I mean, it is the India Cultural Center. We're still hoping to capture as many South Asians as possible. People that had lived here for some time, about 9 years on average in Utah, but quite a large spread. people that were recent transplants, people that have been here for quite some time. Interestingly, on the bottom left, this is a population that, generally speaking, I would say is well educated. What I mean by that is you can see a lot of bachelor's degrees, master's degrees, and then even graduate level degrees. On the right, from a medical perspective, people self-reported a reasonable amount of diabetes, hypertension, hyperlipidemia, things that, as you can imagine, as a cardiologist and a researcher, I cared a lot about that information. People also reported issues including gestational diabetes, a lot of family history of heart attacks, a lot of family history of diabetes, not a lot of tobacco use. Most people had some form of health insurance. And then we did ask some of these public health issues about what are your barriers to routine cardiovascular screening. And no surprise, a lot of people reported time as being a significant issue. And I think we touched upon that earlier too. If you're working a couple of jobs, it's hard to make time to actually go and get a checkup. The results of our 100 and almost 180 individuals, everything that's bolded in the middle is technically at least slightly abnormal or elevated. The numbers that we saw here probably reflect a lot of the other South Asian cohorts that have been studied in the United States. The blood pressures were not terribly elevated. People do skew towards obesity. Obesity as defined by a higher body mass index. A lot of people in this community do have higher body mass indices. Waist circumference is something that's been studied closely, particularly among South Asians, because a lot, as you guys probably know, as you may know, different communities, different ethnic backgrounds may carry fat in different places. South Asians tend to, generally speaking, carry it closer to their abdomen. So a lot of people feel measuring that waist circumference around their body can probably give a little bit more insight than body mass index in terms of their heart disease risk. So we measured everyone's waist circumference as well. We measured their cholesterol, which is total cholesterol, LDL or bad cholesterol, HDL or good cholesterol, triglycerides, and then we did measure two of the kind of newer kids on the block from a prevention standpoint. These are different cholesterol markers that are being studied both in research and by drug companies that are working on making therapeutics that can actually lower these levels and help prevent heart attacks. This is called lipoprotein A and apolipoprotein B. The class portion, as I mentioned, we had 8 sessions total, and we covered these topics. The first one was basically bring everyone in to talk about your test results. And then we went through topics including eating more fruits and vegetables, getting more exercise, stress management, being active every day, nutrition labels, food logging, social cues, how to eat well when you're still eating out, how to eat well when you're eating with family or at family events, and then how to stay motivated long term. The curriculum was designed based off Northwestern University in Chicago. They have a researcher there that I work closely with. She has R01 funding for a program called the Saheli program. The Saheli program worked with community partners in the Chicago area to educate and improve cardiovascular disease amongst South Asians in Illinois or in the Chicago area. And we actually were able to use their curriculum. And the classes were led by a various number of members of my team. It wasn't just myself. We had a cardiology fellow, a medical student, and then a public health researcher as well. And we took turns leading the classes for the group. I'll come back to this. I do want to share some of the participant feedback. So at the very last session, we collected qualitative feedback. Probably doesn't project extremely well, but some of the general themes that came up when we asked people, okay, you sat through 9 months of our class, tell us what's changed. Things that included checking food labels more regularly, increasing physical activity, stress management, suggestions or ideas, improving sleep habits, and then some reduction in sugar intake were general themes. There's a lot of direct quotes that we have that, again, we're working on writing in a formal manuscript, but a lot of the qualitative feedback by the people that started the 9-month program and finished it, which by the end it was about 22 people that finished the entire program, was mostly positive, and I'm not terribly surprised because they were willing to stick with it. We did compensate them around $190 in terms of gift cards if they were able to complete the majority of the sessions, because we understood that people were going to miss some sessions. And then I mentioned, from a science perspective, what we hoped was that this improved their heart disease risk factors, right? They complete the program, maybe they take on different lifestyle changes, and my hope was that their cholesterols looked better, their blood pressures lowered, their diabetes was improved. That did not happen, unfortunately. We had a few trends, including the diastolic blood pressure dropping a small amount, but there was not a significant change. And this is a hard thing to show, generally speaking, when you're studying a lifestyle-based intervention with a pretty small group of people, which is 21. It only takes, unfortunately, a few people who, and there were a few, who self-admitted that, they traveled back home to India for 3 weeks, and they went to a wedding, and everything kind of fell apart at all these celebrations, and they admitted that their numbers went in the wrong direction. So our hope was that we actually improved some of these metrics, but that's okay. This is the reason why we do research. And then so the conclusions, and then hopefully, number one, we can hear from Sarath as well, but also just have some discussion about what a good partnership looks like. We really worked well with the CCET to make our own community advisory board that advised us along the entire pathway of our project. And again, as a researcher who is new to this area, it was very important for me. We used a survey to confirm there was interest in this issue. We did 2 large screening events last summer that I would say were actually very successful. We did comprehensive heart disease reports to almost 180 people. We confirmed that just because you're living in Utah, if you're South Asian, you still have a lot of the same issues as if you don't live in Utah. So this is more obesity, higher bad cholesterol, higher LPA, ApoB, and lower good cholesterol. We did compare men versus women in our groups, and they looked pretty similar. And then, as I mentioned, we did a 9-month health education intervention program. It did not dramatically reduce the risk of heart disease, but the feedback was very positive. And even afterwards, people were asking us, let's do this again next year, let's make it bigger, let's make it virtual. So future steps, we do have we're discussed future screening events as a long-term partnership. We do have banked plasma, so we did put some of the extra blood in a freezer, and we're working with some of the research teams at the university to do some additional analyses. And then, as I mentioned, we're writing up the results. And importantly, one of our goals is to actually get these results back to the Community Advisory Board, to the ICC community, because we don't want the research to occur in a silo. We want to get it back to the community so they know that all the hard work and time they spent working with us, it actually helps the greater scientific community as well. So thank you guys for your time. Thank you for your attention. This is our team. It was a giant team. On the top left, our research team. Again, I mentioned my co-principal investigator was Krishna Sundar. He couldn't be here today. I had a research team that helped me along the way. Clinical team, community leaders that are here today. And then, of course, the funding was by this entire team here, the CTSI CAPP. So it was a fantastic effort. You see, we've already presented some of this work at national cardiology meetings. We had a t-shirt with our logo on it. It was a wonderful experience, and I can tell you just from my own perspective, I learned a heck of a lot about what community engaged research is, because I came in with 0 experience in this field, and I learned a tremendous amount about how you can actually build good partnerships. So thanks for your time. And maybe we can, so Sarah joined us a little of the way through into the project. We had another community leader who was actually our original co-investigator, and then he moved out of Utah. And so he was very willing to kind of take over from a leadership perspective on the community side. And, I would ask you just what was your experience like working with all of this, because I shared all of my opinions.
Thank you. Thanks, Kevin.
Yeah.
From a community perspective, we were so glad to have Kevin and his team come and collaborate with us at India Cultural Center and our community. People weren't aware of this program that happens here in Utah, and I was known that it has been happening for past 15 years. And it was the first time that we came to know about the event, and Kevin was so helpful in helping us for the past 8 to 9 months. And that collaboration with the researchers was so great that community members really wanted it to continue. Like he already mentioned that people have been asking us, hey, when it's going to happen again? We used to do a lot of blood drives every year, like we have 1 or 2 blood drives every year, but this detailed blood sampling and other details that they shared to the community was so awesome that even I got my high risk factor, but, but that those kind of details that they shared, community really liked it and they wanted to continue. And thanks to the team to give us the funding and help this program continue. So, and from a cultural, our ICC perspective, our mission is also to give education back to the community. So this research and this program was definitely a win for us, a win-win for the researchers and us. So thanks to Kevin and thanks to the team. Thank you.
So can you talk about some of the non-traditional methods you used, if any, that you think made your project successful?
I think a lot of the success, some of the themes that were mentioned today, I think the research team that we kind of put together was built of people, many people of South Asian background, but not all. But I'll even say that some of them on my research team, and I'm born and raised in the United States. My parents immigrated here from India. There are a few people on my research team that are born and raised in India. And I could tell when they led some of our sessions, and they were part of this community, some of the connections, ties, the personal relationships were just different, right? And they're going to be different because they're connecting with someone else who immigrated on the same timeline that they did. So I think having a research team that, number one, cared about the issue, and then number two, looked like the community in some way, shape, or form made a big difference. I think having some motivated medical students, undergraduate students that were willing to spend their time on a weekend and posting flyers at every restaurant and every Indian restaurant in town helps, right? And then also having those conversations, frankly, even myself going into restaurants and saying, hey, I'm doing this big health drive. Can I put this in your window? My goal is to help increase awareness for South Asians locally. No restaurant said no. Everyone said, yeah, of course, put it up here and we'll take it down whenever we can. So I think having motivated people, having a research team that does reflect some of the same cultural values probably helped a lot. And it helped me because there were some sessions where we were talking about certain topics that I felt reasonably comfortable with, and I would talk to my team about who's going to present this section. I could tell there were people more comfortable than myself, more familiar with some of the topics, and I said, this is perfect. We should let you discuss this issue more because it's just more familiar for you.
And I think the numbers showed that too. Like their target when we spoke was 100. Like he was saying, yeah, we should be able to get 100 people. That would be a good one. But finally, in 2 sessions, we had like 170 people. So that really showed how they were able to engage with the people and help them come in for the sessions.
So you mentioned that the research was 9 months long,
Mm-hmm.
and you had 21 participants.
Mm-hmm.
That stayed steady. Is that different from the number that
Well, So we had a huge drop-off. I didn't actually mention that. We did. And that's a big issue, I think, my understanding in community engagement research is how do you keep people in, particularly for a long-term project. I think our first session was after people had their screening tests and their results were given to them, maybe 2 or 3 weeks afterwards. It was come to this first session. We're going to review what all of these things mean, and we're going to introduce you to the rest of the curriculum. Our first session was either high 30s or low 40s, maybe high 30s, of people came to that first session to hear about what these test results mean. And then from the first to the second, there was some drop off, and then the second to the third, we kind of plateaued in the 20s, 21 to 25, somewhere in there. And then from there, through winter, through spring, by the time spring came, we landed at around 21. So we had the drop off was significant. So what we decided to do was the goal is to have a minimum of 5 of the 8 sessions because we felt that if somebody participated in fewer than 5, it would be hard to really test the question of does this program help your heart health if you only came to 1 or 2 sessions. And so instead of saying we're going to give you $20 per session, we said come to a minimum of 5 out of 8, and that'll break you in at I think 150. And then going from 5 to 6, 6 to 7, 7 to 8, we'll add incremental gift card value. And I think the people that stayed through the end, we collected a lot of their feedback on this. A lot of them, I don't think the gift cards meant as much as actually doing the program. And we have the contacts of the original 40 some odd people that began, and we still need to reach out to them to understand what was it about this undertaking that wasn't something you wanted to do. Because it was all on the weekends. It was at the ICC. It was in person. But again, it was 1 hour of their day on the weekends.
How long were your sessions?
1 hour. 1 hour. And our hope was that for a lot of people, this center is somewhere that they're either spending time at anyways, or it's at least a familiar place, so it's not completely out of the way. But there were certainly a lot of people that dropped out.
Oh, no, sorry. No, you're fine. I was just wondering how you formed your partnership and kind of went through the roles and responsibilities and how to go about it.
Yeah, for our end, it started myself and Dr. Sundar were sort of the academic investigators. And then his predecessor, Balaji, was our community leader. But I mean, this started off with, this is probably 2.5 years ago, a lot of phone calls and a lot of in-person meetings about, this is what I'm hoping to accomplish for the community here. And then, as he mentioned, someone from the ICC side saying, yeah, these are similar goals. Like, we want to help and educate our community. You want to help and educate our community. And there's a research funding opportunity here that may make a lot of sense. So let's build the actual partnership to get something off the ground. Once things were in motion, honestly, everyone worked really well together. It certainly helped that we had enough funding to cover compensation, to cover, some of the CCET work. Like, that makes a big difference, I think. But yeah, it was just a lot of frequent communication early on and building that trust that, this research team is not just here, like I said earlier, to grab samples and get the heck out of there, but they're really vested in this issue and this mission.
I think it will be very interesting. I've heard you saying like all the time that needed to be invested to connect with your participants, with your project, and also that there was a lot of dropouts of the project. And so I think, and you're working with a population that is different than the Hispanic population. So I think it will be interesting as a researchers to present to all the communities. I mean, what makes us different to work with by community, and perhaps it will be a surprise that it's very similar among the different diverse groups, and so maybe it's more work for the researchers to adapt to what the majority is going through to be able to work with you. So I don't know, just a thought that I thought might be interested. I'm so into the Hispanic community that
Sure.
it's like I'm inside the box.
Right.
Thinking in our barriers, our challenges,
Right.
and all that. But as I've heard about your project, it's like, well, there's so many things that are similar.
Yeah, yeah, of course.
So like,
Back
go
over.
ahead. I'm really curious. I know this was funded here, this 1-year funding. So what you learned from this? What's the next step? Did you secure additional funding from here? What are
Yeah.
your next research questions? Like, where does this go?
I know. That's the $1 million question. We were still planning to apply for, there's a funding agency called WIN, Robert Wynn. That's just the name of a researcher, and they have career development awards. And we wanted to use this to leverage to try to spin that into a 3-year type of project. That's one. Two, we haven't actually looked at our frozen samples yet. And that is much more, that research I would say is much more tailored towards probably more translational science research, but there's still a lot to be learned there. And so we haven't even opened up the freezer yet to kind of deep dive into those samples. And then lastly, even beyond additional funding, and we were just talking about this a few minutes ago, there's a lot of clinicians at the University of Utah that I think would love and be excited to provide educational opportunities on the areas that they're passionate about that are relevant to this community. And I mentioned some of them. diabetes, obesity, heart disease. So I think even if it's establishing a once a year type of forum where clinicians who care about this community can come and speak again at the community center, I think would be the easiest, lowest hanging fruit that could probably be a win-win, because they get to help serve the community and the community gets to know who all these people are, that they're not locked up in some ivory tower, but they actually can come and really provide some useful information.
Yeah, even we were chatting yesterday to know how many Indian physicians are in Utah. We both didn't know. So then we finally ended up getting an answer that there's nearly 100 Indian physicians out in the valley. So, those are things that are not known to the community. Now, with the partnerships that we are trying to get more engagement and get more educational things back to the community.
I appreciate that. It's I think in researching it's so about like that p-value,
Yes.
It's like, okay, maybe you didn't find everything you wanted and there's a confounding factor for that, but I love hearing it's like, okay, with just visibility of this community and getting
Bingo.
engaged this way and people passionate about it, maybe like a bigger impact and also you have these growth samples. That's great to hear.
Thank you.
In our case, we have experience of bringing the researcher to community engagement, community event.
Yeah.
And he was doing fiber scans for fatty liver detection.
Really?
And just in the open screening, we found that there's people living with cirrhosis or cancer that they didn't know, of course. So that made us go like a couple years after, because of COVID and everything, to do and implement and screening for the Hispanic community. So it's kind of like having the person being in the community. The community health workers are the best network of people to implement whatever program we are doing here. And little funding to seed another project so we can keep going and navigating those people throughout the commitment for good diet and physical activity, but also partnering with other programs that we have, because everybody's trying to do the same at but different places, like the DPP adequation, the cardiovascular prevention, etc., and everything is in the same scenario. So the idea of doing this is to eventually not only building the reach for the to connect the other projects, because I want to have like nutrition and exercise, but I don't have it in my budget right now. So because I'm going to do my follow-up at 6 months to see how better, like how it changed. But like this means even the community-based organizations, we can do like a big database of research, of course, with the institutions, but we are collecting a lot of data that is not written in papers, and that's where we really need to team up, because we need to bring this information up to not only the NIH, whatever, but the decision makers to see here, this is a potential problem that we have to stop right there. Well, so I think this is a very important thing that like everybody is putting a little bit of information up there. So thanks.
The project, it's a great project, and I think like putting on my investigator hat, we will call this kind of an intervention development project. For a project like this, sometimes like both the researcher and the community members may have little clue like what works the best. Because like for example, Kevin's project is, we would call it rather intensive intervention. And the dropout rate that we're seeing, we don't know whether or not it's good or bad, because like it's intensive. Like and he's the first time doing this, so the dropout rate, wow, it sounds huge, but it may be if we give it to like everyone in the community, we will see the same dropout rate. And another thing about pilot project I want to point out is like Kevin was showing us that table, and then most of the measure you don't see any difference. But that's a pilot project. We are not what we call powered to find difference. Like he only have 21 people. Like it will take a really, really excellent intervention program to find difference. So in pilot project, we're really focusing on whether or not this is feasible and whether or not this is acceptable. And I think this is where we need to kind of like when, as community members, when you go into partner with an investigator for a project like this as a pilot, let's get together and find out whether or not this is even workable, even feasible, right? And that's kind of our yardstick. We're not trying to really kind of make any big changes. Kevin's next step is what going to be making changes, and kind of this is kind of the perspective I want to like inject, like and yeah, excellent project.